Welcome to Clinicals with PharmVic. Today I will be talking about classification of contraceptive methods and drug interactions with hormonal contraceptives. Contraceptive methods can be classified by their mechanism of action or duration of action. One major classification is the long-acting reversible contraception, LARCs. These include intrauterine contraceptive devices, IUDs, divided into levonorgestrel releasing and copper intrauterine IUDs, and the etonogestrel contraceptive implant. Another major classification of contraceptive methods is the shorter-acting hormonal contraception. These include the depot-medroxyprogesterone injection, the progestogen-only contraceptive pills and combined hormonal contraception, combined oral contraceptives, COCs, and the contraceptive vaginal ring. Another major classification of contraceptive methods is the barrier methods of contraception. These include the male external and female internal condoms and diaphragm. Another major classification of contraceptive methods is the sterilization method. These include vasectomy and tubal sterilization. Other contraceptive methods include fertility awareness methods, lactational amenorrhea method, withdrawal method, and emergency oral contraception. What are the factors affecting contraceptive choice? Contraceptive choice is influenced by multiple factors. Medical practitioners must ensure the safety of the method for the individual situation and support informed decision-making based on patient preference. Contraception may be relevant to all individuals, regardless of gender identity. Conception may be possible for anyone presumed female at birth. This includes cis women, trans men, and some non-binary individuals. Contraception may also be relevant to anyone presumed male at birth. This includes cis men, trans women, and some non-binary individuals. The factors include contraindications and precautions. Potential for drug interactions. Effectiveness of the contraceptive method and consequences of unintended pregnancy. Need for immediate start, including quick start of hormonal contraceptives. Reproductive stage of life. Time frame for planned pregnancies. Return of fertility may be delayed with depot-medroxyprogesterone injection. Mechanism of action. A method that does not prevent implantation or ovulation may be preferred for religious or cultural reasons. Reversibility. Non-contraceptive benefits such as improvement in acne, dysmenorrhea, or heavy menstrual bleeding with some hormonal contraceptives. Cost and accessibility. Long-acting reversible contraception is the most reliable and cost-effective reversible method of contraception. If reliability and cost-effectiveness are paramount, long-acting reversible contraception, LARC, is an appropriate choice for females of all ages. LARCs include the etonogestrel subcutaneous implant, levonorgestrel releasing intrauterine contraceptive devices, LNG IUDs, and copper IUDs. Misinformation and misperceptions about adverse effects and contraindications of LARCs are common. Ensure awareness of the available LARC methods and their ease of use, efficacy, and safety, including in young nulliparous individuals. Intrauterine contraceptive devices can be safely used by young nulliparous individuals. Drug interactions with hormonal contraceptives. Drug interactions with hormonal contraceptives can result in decreased effectiveness of the contraceptive. Hormonal contraceptives can also affect the metabolism of some drugs, resulting in either a decreased effect of the drug or risk of toxicity. Check for drug interactions, including with over-the-counter and complementary medicines, when starting a hormonal contraceptive or any new drug. Although griseofulvin does not induce cytochrome P450 liver enzymes, the effectiveness of hormonal contraceptives may be reduced by concurrent use. Efficacy of combined hormonal contraceptives, all progestogen-only contraceptive pills, POPs, and the etonogestrel implant may be reduced in individuals taking lamotrigine. Some studies have shown a small reduction in plasma levonorgestrel concentrations and an increase in follicle-stimulating hormone FSH and luteinizing hormone LH concentrations. The clinical significance is not known, but additional reliable use of condoms is advisable for patients using lamotrigine and combined hormonal contraception, progestogen-only pills, or the etonogestrel implant. Contraceptive effectiveness of depot-medroxyprogesterone acetate and levonorgestrel-releasing IUDs is not expected to be affected by lamotrigine. Drugs that affect hormonal contraceptives. Most significant drug interactions with hormonal contraceptives are due to induction of cytochrome P450 liver enzymes. Enzyme-inducing drugs increase the metabolism of both estrogens and progestogens and decrease effectiveness of all hormonal contraceptives other than levonorgestrel-releasing intrauterine contraceptive devices, IUDs, and depot-medroxyprogesterone. Copper IUDs, which are non-hormonal contraceptives, are also unaffected by enzyme-inducing drugs. Levonorgestrel-releasing or copper IUDs and depot-medroxyprogesterone are effective in individuals taking enzyme-inducing drugs. Enzyme-inducing drugs that decrease the effectiveness of hormonal contraceptives include the antiepileptics carbamazepine, oxcarbazepine, perampanel at doses of more than 8 mg daily, phenobarbital, phenobarbitone, phenytoin, primidone, rufinamide, and topiramate at any dose. Some drugs used to treat viral infections such as HIV, viral hepatitis, and coronavirus, COVID-19. The antibiotics rifampicin and rifabutin. Some complementary medicines, for example, St. John's wort. Other drugs, for example, aprepitant, modafinil, bosentan. The only antibiotics that interact with hormonal contraceptives are those that induce liver enzymes like rifampicin and rifabutin. Drugs affected by hormonal contraceptives. The plasma concentration of some drugs can be affected by hormonal contraceptives. Monitoring of drug levels or effects may be required. Effects of hormonal contraception on lamotrigine. Combined hormonal contraceptives increase the metabolism of lamotrigine. This can result in significantly lower serum lamotrigine concentrations, reduced effect, while taking active hormone pills, and may result in increased concentrations, risk of toxicity during the hormone-free interval. If a combined hormonal contraceptive is the most suitable option for a patient, continuous use without a hormone-free interval, of a combined oral contraceptive pill or vaginal ring. This avoids cyclical changes in lamotrigine concentrations. Measure serum lamotrigine concentrations after starting these contraceptives because lamotrigine dosage may need to be increased, possibly up to twofold, to maintain efficacy. Extrapolating from evidence on the desogestrel progestogen-only pill, use of any form of progestogen-only contraception may increase the risk of lamotrigine toxicity. Advise patients taking lamotrigine who start progestogen-only contraception to alert their clinician to any symptoms of toxicity such as dizziness, coordination difficulties, or double vision. When starting or stopping hormonal contraception for a patient taking lamotrigine, consult the patient's neurologist or psychiatrist so that any dose adjustments required can be made. Effectiveness of a contraceptive method may be paramount if pregnancy would pose a serious health risk, for example in those with cardiac failure, recent breast cancer, some mental health conditions, or complex psychosocial situations. Typical use, effectiveness, and perfect use, efficacy, can vary by population. Younger people generally experience higher failure rates, reduced effectiveness, because they have higher background fertility than older people. Long-acting reversible contraception, LARC, which includes intrauterine contraceptive devices, IUDs, and the etonogestrel implant, is the most effective reversible method of contraception. Starting hormonal contraception without delay, quick start. Hormonal contraception is traditionally started at the beginning of the next normal menstrual period, within the first 5 days of the menstrual cycle, to avoid the risk that the individual is already pregnant. Or it also avoids the need for an additional method of contraception for the first 7 days, because hormonal contraception is immediately effective if started at this time. Quick start refers to starting a hormonal contraceptive immediately at the time of consultation, even if it is later than day 5 of the menstrual cycle, when it may be impossible to exclude an early pregnancy. If following oral emergency contraception, quick start can be used immediately after taking levonorgestrel, but not until 5 days, 120 hours after taking ulipristal. Quick start can be used for all methods of contraception other than levonorgestrel releasing and copper intrauterine contraceptive devices IUDs, because early pregnancy must be excluded before starting an IUD. IUDs can cause harm to a continuing pregnancy, including late miscarriage and premature delivery, if the IUD cannot be safely removed. Combined oral contraceptives containing cyproterone, unless pregnancy can be reasonably excluded, because there is a theoretical risk of feminization of a male fetus. Quick start can be considered for anyone presenting for hormonal contraception, but is particularly useful if the menstrual cycle is long or irregular. Unintended pregnancy would pose medical or psychological harm to avoid delay in contraception. There may be difficulties accessing health services at a later time, for example for insertion of the etonogestrel implant. If using the quick start approach, ensure the individual is aware that as early pregnancy has not been excluded, a pregnancy test is required 4 weeks after starting the contraceptive or 3 weeks after starting if no further episodes of unprotected sex occurred in the first week of use, regardless of whether bleeding occurs. There are no known teratogenic effects from the contraceptive method. The method will take 7 days to become effective, or 48 hours for those progestogen-only pills that contain levonorgestrel or norethistérone. Please subscribe, like, and share the video. Someone might need to watch this video. Thank you, clinicians.